Hey guys, what's up? This is Stephanie. Welcome back to my channel. So in the video today, I'm going to be discussing my second month in a physician assistant critical care medicine residency. So for those of you who are interested in applying to just a residency/fellowship after PA school, hopefully this video is of interest of you and of help to you. That way you can kind of see how the process has been for me. So a little bit about me real quick for those of you who are not familiar. I am currently a physician assistant who graduated last year in the fall of 2020, specifically December 2020. I wanted to do critical care medicine, so I decided to apply to a residency, a very competitive residency/fellowship. Thankfully, I was accepted. So the residency/fellowship that I'm in only accepts two residents, and it's an advanced practice provider critical care medicine residency/fellowship, which also includes nurse practitioners and physician assistants. So nurse practitioners and both physician assistants are applying to this program, and they only accept two. Thankfully, I was one of the physician assistants that got accepted into the residency for this year, and it's a year-long residency. We do basically 13 rotations, and you rotate through a number of critical care medicine specialties or units, ICUs. So those include surgical trauma ICU, neurovascular ICU, neurotrauma ICU, surgical ICU, cardiothoracic ICU, transplant ICU, rapid response team, etc. And then on top of that, at the end of the fellowship/residency, you have a few months of elective where you can actually rotate in wherever you like, depending on what specialty you want to go into. So for example, if I'm interested in surgical trauma, I can do a rotation at the surgical trauma bay where they actually get the patients that come in just from, for example, where they found them, and you'll be able to be in the OR with them. If, for example, which is something I want to do also, I'm very bad with reading scans, whether it's MRI or CT scans. I can also do a rotation in radiology, which is where I can familiarize myself with MRIs or CT scans. If I want to go into post-cardiac arrest, there's a rotation for that, etc. So just depending on what I want to specialize in regards to critical care medicine, then I can do those elective rotations there, which is something I really liked about the residency. In addition to that, what are my hours like? So I work 6 days a week. Usually I have 1 day off, depending on what rotation it is. If it's a rotation where the hours are longer, meaning that I work, for example, more than 12 or 13 hours, and sometimes I'll get 2 days off, and that sometimes also includes a 24-hour long shift. And I work alongside fellows and residents. So I work the same hours as they do, and I usually am in rotations with the fellows and residents. So that's another thing that I really like, is that they treat you equal and that you're with them learning. So that's something I really like about this residency. So let's get back into it. That's just a little bit about the residency and fellowship. So I finally completed my second month in my residency/fellowship physician assistant for physician assistants, nurse practitioners, advanced practice providers, and I completed my second month in the Neurotrauma ICU unit. So my first month, if you haven't seen the video yet, I will link the video below in the description. I had completed a month in the surgical trauma ICU. Definitely was a huge learning curve because it's a whole different world. And in PA school, we don't really learn a lot about critical care medicine. We don't really learn about ventilators, for example, how to manage ventilators. We don't learn a lot about certain, for example, medications that are given in the ICU units. What are arterial lines? What are central lines? What are the indications for arterial lines? What are the indications of central lines? How do you troubleshoot a ventilator, etc.? And so it was definitely a huge learning point for me, and it is still. So my second rotation, I did it in the neurotrauma unit. What is neurotrauma? Basically, we got a lot of patients that had injuries, of course, neurologically. And it's called neurotrauma because a lot of them would have, for example, trauma to the head, whether it was intentional or non-intentional. So intentional was, for example, gunshot wounds to the head. Other injuries were, for example, any injuries to the spinal cord, whether it was in a motor vehicle accident. For example, we think about our accidents where the patient hyperextends their spinal cord or hyperflexes their spinal cord. Also falls, of course, where they injured any part of their spinal cord. This rotation, I will be honest, it did involve a lot of patients dying. It involved a lot of death. And so I had to familiarize myself on how to give bad news to patients' family members. And I had to also familiarize myself on, for example, patients that want to donate their bodies. What do we do to prepare the body when the patient is dying so that the patient can donate their organs? And that was something, of course, that they don't really teach you in PA school. I was very thankful that I was able to learn that for this rotation. But in general, I would say I thoroughly enjoyed this rotation. What was my schedule like? It was 6 days a week. I would go in at 6 a.m., get off at 4 p.m., sometimes a little later, 5 or 6, depending on how busy the ICU was. And then I would have 1 day off. We would start rounds at around 8 to 8:30, and we would finish rounds until sometimes 12 or 1, depending on, of course, how complicated the patient was. And I learned a lot during this rotation. Like I discussed, also we had a lot of subarachnoid hemorrhages in PA school. You learn very little about a subarachnoid hemorrhage, just the basics. And here in neurotrauma, you learn a lot. Like, what is the cap for this patient, systolic blood pressure cap? How high can their blood pressure go in order to be perfusing the brain? And if the cap is too high, if the patient is too hypertensive, what medications are going to be giving the patient to ensure that you control that hypertension? In addition to that, if the patient is not meeting that cap, or for example, if they have a MAP floor, mean arterial pressure, that is 80 and they're under that, what medications are you give the patient so that you can ensure that the patient is actually above that mean arterial pressure? And we worked very closely also with neurology, because sometimes we would get overflow from the neurovascular ICU. So we would get some stroke patients, and we worked very closely with neurology, managing stroke patients. We worked very, very closely with neurosurgery in regards to patients that were post-operative. So any patient that had any type of injury to the spinal cord, for example, whether it was in accidental, like we discussed, or even sometimes I had certain patients that just had metastasis from cancers. That was something that was very, very common. That would metastasize to the spinal cord. And sometimes I had patients that had very serious injuries, especially I had a lot of young patients. So I think that's what was really hard about this rotation, is that I had 18-year-olds, 16-year-olds, 15, 14-year-olds that sometimes had very severe trauma to their spine, where they became quadriplegics or just paraplegics in general. And it was really difficult having to have that conversation with the family members, like I discussed. And then also having the beauty in some of these things is that sometimes these patients were organ donors. So we would be working together with CORE, who are individuals that are responsible for ensuring that the patient's body is prepared for when they transplant their organs. So like I discussed, that was something that I really learned. I got to see several brain death tests, which is something I've never seen and was very, very briefly taught in PA school. Specifically, I remember watching a video on osmosis in regards to what is taught during brain tests, or what do you look for in brain tests. And I was able to sit in and see several of these of how the cranial nerves are tested to see if the patient is actually brain dead or not. And so that was very, very interesting. I got to see those. And in addition to that, I got really good with my neurological exams. And in neuro, I was just really bad. I remember with my neuro exams, and this rotation really helped me improve my neuro exam. The nurses are fantastic in regards to the neuro exams. They're doing them constantly, sometimes every hour, every 2, every 3, every 4, depending on, of course, how serious the injury is of the patient. So any change in the patient's neurological exam, so say, for example, they're removing their left lower extremity and now they're not moving that extremity anymore, then of course it will let us know, and then we would also let neurosurgery know, because sometimes if it's any type of brain injury, they would have to go back to the OR to decompress the brain injury, because a lot of these patients that have any type of bleeds or even strokes, they tend to herniate. So that was something that I learned during this rotation. I got really good with my neuro exams. So just so I can keep this video short and sweet, How did my second month go? I do have to say that I feel like I've improved a little bit. And during this rotation, it was usually me. I had a dental anesthesiologist resident with me, and then I also had a fellow. So fellow was my fellow that I was with. She was an anesthesiologist who is a board certified anesthesiologist who wanted to get certified in critical care medicine also. So she's doing a critical care medicine residency fellowship with us. And so she was with us, and it would be us three for the patients. So sometimes there would be days where it was just me, the dental resident, and then of course I had my attending. And those days is where I felt like I kind of was pushed, and I learned a lot because it was just you, and the nurses would go up to you and they look to you and ask you, what do you want to do with these patients, especially if the patient was seizing, if the patient started having a change in the neurological exam. I remember on my last day, I was panicking because I had a patient that had just been placed a pigtail. And I remember that I looked at the x-ray afterwards, because whenever a pigtail or any chest tube is placed into the thoracic cavity, you have to make sure that you get an x-ray afterwards to ensure that there's not any type of pneumothorax or any lung problem. And so in the chest x-ray, I looked at the chest x-ray, and of course in PA school they teach you how to read chest x-rays, but you really self-teach yourself, or physicians or residents or fellows in my case would teach me how to properly read a chest x-ray. So I was looking at this chest x-ray, and I was with an orthopedic resident who was fantastic, but she would tell me, you know what, when it comes down to x-rays of the bones, I'm good at those, but chest x-rays, those are not my forte. So it was just me and her, and I remember looking at the chest x-ray, and I looked at it, and I was all, you know what, that looks like a pneumothorax, and you can definitely see the line, right, and the difference between the blackness, which is, of course, just black, and then just air, and the difference between the lungs. So I went up to the room, and I go into the patient's room, and the first thing I do is I look at the patient's stats, like what's his oxygen level. He was perfectly fine on his oxygen level, but of course, he did have a tracheostomy, but he was breathing fine. And then I looked at his blood pressure, at his heart rate. The patient was fine. And so then I look at his physical exam, and I'm talking to him, and he's breathing like this. And I was like, okay, that is not normal. So I look at him, I'm like, are you okay? And he's like, yeah. And he was like, are you okay? Because I think he just saw how much worry I had in my face, and he was just breathing like this. And so then I remember grabbing the phone. I ended up calling the doctor that was there on call for critical care medicine, and he came in and started looking at the x-ray. He's like, yeah, that's pneumothorax. I'm very glad you caught it. So they ended up just removing the pigtail and then just placing a new one. But I was very proud of myself because I was able to catch that, even though the patient looked fine monitor-wise. If you looked at him in the physical exam and I listened to his lungs, of course, absent lung sounds, he was just breathing like this. And so that was something that I felt really good about because I was by myself and I was able to catch that, and I did something for the patient. But in regards to how I feel in comparison to the first month to the second month, I do feel a little bit more comfortable seeing patient. Neurotrauma is a whole different world in comparison to surgical trauma. I got very comfortable with reading CT scans of the head, the brain, of the spine. I got very comfortable reading MRIs of the head, the brain. I got very comfortable with those. And so that's what I really think this rotation for. I was able to I was pushed, of course, to my limits when it was just me and another co-resident, like a dental resident, who does know a lot about medicine, but not as much. And so we both worked together to make sure we were treating the patients, of course, and giving them the appropriate care. So that was this rotation.